Okay, so let's start with early stage disease. So an interesting study from China in HER2-positive cancers asking the question of whether neoadjuvant taxane, trastuzumab, and pertuzumab is non-inferior to standard TCHP neoadjuvant treatment. Essentially, the question is, do you really need the carbo? And just to level set, the original reason to include carboplatin in this regimen was based on... okay. Yeah, no, sorry. Should be able to do it. Yeah, that's good.
Oh, what happened? Oh, no, it's not. Slideshow it? Oh.
Yeah, the problem with the other display is it shows you what your next slide is, and so you lose that surprise that we all look forward to. So, problem is then it's very small for me to see. So the question is, do you really need the carboplatin? And there's no clinical data right now that compellingly says you do. So this is really an important trial to ask that question. So they randomized almost 800 patients to either standard 6 cycles of TCHP or 6 cycles of THP without the platinum. This was the taxane was dealer's choice, but it had to be every 3-week treatment, so no weekly taxane. So 3/4 of the patients were stage 2, the other quarter was stage 3. And here's the primary endpoint, progression PCR. You can see essentially identical, less than 2% difference. This clearly met the non-inferiority boundary of 10%. And it didn't matter whether it was ER positive or ER negative, HER2 positive, same thing. If you look at the subgroups, the only one I want to call attention to was those cancers that were HER2 2+, but FISH amplified. This was a very small group, but they did very poorly in terms of PCR, less than 30% in both arms of the study, but particularly poorly in the THP arm, suggesting perhaps that in these cancers that really probably aren't very HER2 driven, you need more chemotherapy. As you would expect, toxicity was better in the arm that did not have carboplatin, so there was less myelosuppression, GI tox, and renal toxicity. So in summary, THP for 6 cycles is non-inferior to TCHP, and it had less toxicity. I really think now, based on this, that we can start considering using non-carboplatin THP regimen as our standard of care. Whether you do 6 cycles, as was done here, or 4 cycles, I think we'll have to kind of talk amongst ourselves, and it may vary by which patient who's sitting in front of you at the time. The caveats of this are that we have really minimal long-term outcome data with just a THP regimen that will be addressed in the long-term outcome data for COMPASS, which should be out hopefully in the next couple of years. Also, as I said, for the HER2 2+ cancers, we don't have a lot of data for them in a regimen like this. They don't seem to do as well, and so you may, for now, consider giving more chemotherapy with a platinum for those patients, as well as the very high risk, like stage 3B patients. This whole field is going to get blown up after ESMO, though, because we're going to have new data with TDXD, trastuzumab deruxtecan, both DB11, which is the neoadjuvant TDXD study, as well as the DB05, which is the adjuvant TDXD after patients receive neoadjuvant therapy and have residual disease. This just got announced yesterday. So we'll have both of those trials at ESMO, and it'll really be interesting to have all of these different potential options for early disease HER2 positive patients. Switching to hormone receptor positive disease, we saw very nice long-term outcome data from the SOFT and TEXT trials. These are the trials that asked whether ovarian suppression was helpful and using it with an aromatase inhibitor or tamoxifen in patients with premenopausal ER-positive cancers. So fortunately, with 15 years of follow-up, we still see substantial benefit with ovarian suppression and as well as switching to an AI. But really, in terms of the absolute difference, particularly for survival, most of it is predominantly in those patients with high-risk cancers. So high risk as defined by previously having chemotherapy, and particularly for very young patients under the age of 35. You can see huge differences, benefits with the addition of ovarian suppression and then switching to exemestane. That difference, particularly the exemestane versus tamoxifen question, was also substantial benefit seen in those patients, not just under 35, but under 40 as well. So it's a little bit larger group than just the very young patients. And patients with grade 3 tumors also seem to preferentially benefit from the addition of ovarian suppression with exemestane as opposed to with tamoxifen. So we now see durable benefit with ovarian suppression overall and with switching to exemestane. Unfortunately, there continues to be breast cancer events after 15 years, so we have to remember that when we're seeing these patients long after their diagnosis. And the largest absolute benefits are seen in high-risk patients, whether defined as having received chemotherapy, being very young, or having grade 3 tumors. So another I think is a very impactful and interesting study was asking the question of whether endocrine therapy-related hot flashes can be reduced with neurokinin receptor antagonists. And there's preclinical data suggesting that the endocrine therapy-related hot flashes are due to hyperactivity of a specific type of neuron in the hypothalamus, and that this causes the dysfunction of thermoregulation. Inhibiting a particular receptor, neurokinin receptors on these neurons, seems to help reverse this effect. We already have data from I thought I remember how to say this, fezolinetant, I don't think that's it, which is an NK3 antagonist that's approved for treatment of hot flashes in patients without breast cancer, but don't have data yet with this drug in patients with breast cancer, and this drug does have rare hepatotoxicity. A new one of these, elezantinib, which is a dual NK1 and NK3 antagonist, has shown improvements in hot flashes in patients with natural menopause, and now with this trial, OASIS-4, looking at it in patients with breast cancer. So this is randomized over 750 patients with hormone receptor positive breast cancer on an endocrine therapy. It's about half and half tamoxifen and AI. These were patients who had at least 35 moderate to severe hot flashes a week. They were randomized to either upfront elezantinib or a 12-week run-in of placebo followed by switching to the study drug. And what you can see here is the number of hot flashes decreased substantially and very quickly with initiation of elezantinib, and this continued for the whole year of treatment. Severity of hot flashes also was reduced with the drug, and it's pretty well tolerated. There's some mild fatigue, somnolence, and diarrhea with it, but these are relatively infrequent, and there's no LFT abnormality seen so far with this drug. So this does look like the first NK receptor antagonist that has activity in patients with breast cancer on endocrine therapy. It seems to be relatively well tolerated, and I think if this is approved, it really is going to be a welcome and helpful option for patients to improve quality of life as well as probably adherence to the drugs. So let's switch to advanced breast cancer. First, we'll talk about HER2-positive disease in the first line. So we know that trastuzumab deruxtecan is a very active drug in late-line HER2-positive disease as well as second-line disease. And so the question is it also beneficial in first line? And so that was asked in the DESTINY-Breast09 trial, which took patients with first-line HER2-positive metastatic breast cancer and randomized them to the standard of care Cleopatra regimen of THP or T-DXd plus pertuzumab. There was a third arm of this study which looked at T-DXd alone, but this data are not yet available yet. So we're just looking at T-DXd pertuzumab versus THP, and you can see the primary endpoint here clearly favors T-DXd pertuzumab with a median progression-free survival of almost 41 months and a hazard ratio of 0.56. These are pretty early data, so the median PFS is probably going to be even longer with further follow-up. Overall survival is very immature, but trending in the right direction. PFS2 also favors T-DXd, but really only a tiny fraction of the patients on the control arm got T-DXd in subsequent line of therapy, so this really, I don't think, is very interpretable. In terms of safety, I just wanted to point out that when we treat patients with the THP Cleopatra regimen, they typically get the taxane for 6 or 8 cycles, and then you stop the chemotherapy and they're on maintenance HP. There is no natural maintenance phase of TDXD, so those patients basically in this trial were continuing on their cytotoxic agent, in this case TDXD, for much longer, around 25 months, or I'm sorry, 22 months with TDXD. So it's probably going to have different quality of life impacts being on a cytotoxic agent that long. We don't yet have quality of life data on this study. In terms of toxicity, there were no surprises in terms of the toxicities of the 2 arms. There was about a 12% ILD rate with TDXD, in line with what we've seen with other studies. So what about other first-line alternatives? We did recently, last year, see the data from the Patina trial, which looked at patients who were starting the Cleopatra regimen, finished their chemotherapy, were switching, and we're talking specifically about the hormone receptor positive, HER2 positive patients, who switching to hormonal therapy plus HP alone. These patients in this trial are randomized, to HP endocrine therapy with or without the CDK4/6 inhibitor palbociclib. Adding palbo resulted in a substantial improvement in progression-free survival with a median of over 44 months. This is a slightly select population because the only patients who went on this were patients who did well with their with their induction chemotherapy component, but most patients do that. So we have this regimen for the triple positive patients associated also with a very long PFS. So TDXD plus pertuzumab in the first line is associated with unprecedented efficacy. There's no question about that. There are other first-line options like Patina or standard Cleopatra. And we know that TDXD is very effective in second-line therapy. So really the question is not whether or not we're using TDXD or TDXD plus pertuzumab, it's whether you use it in the first line or the second line. And I don't think there's really probably one approach that's going to fit everybody. And I think we probably should be thoughtful about this, and one potential way to select who you're going to give first-line TDXD to are patients who you don't think are going to do well with upfront THP. And we have some data to suggest who those patients are: patients with brain mets, patients with molecular markers like a PIK3CA mutation, or low levels of HER2 mRNA expression. So those factors could be included, as well, of course, is patient preference. But I think having this option is certainly very nice for our patients. And these selection criteria I just noted are likely going to change as we get more data, including quality of life and long-term survival from this regimen. Okay, now with hormone receptor positive disease, we saw this plenary talk, Sharynn 6. This is built on the recognition that patients acquire ESR1 mutations as they go on first-line therapy in the metastatic setting with a CDK4/6 inhibitor and aromatase inhibitor. And you can detect these with ctDNA. So the trial is testing the hypothesis that using a SERD, camizestrant, to treat emerging ESR1 mutations before they have clinical progression could extend the duration of benefit of first-line therapy. And so they embarked on this ambitious trial where they screened over 3,200 patients who had already started their initial CDK4/6 plus AI therapy. They screened them with ctDNA every 2 to 3 months. And identified out of that over 3,200 patients, about 500 patients who had acquired an ESR1 mutation. About half of them acquired it on their first test, the other ones were later tests, and they randomized 315 to either continuing their AI plus CDK4/6 inhibitor or switching to camizestrant, the SERD, plus their same CDK4/6 inhibitor. And what they found was that those patients who switched to Cami had a substantially longer progression-free survival, about 7 months. Difference, hazard ratio, an impressive 0.44. And time to deterioration and quality of life also favored the patients who switched to Cami. In terms of toxicity, both arms were very well tolerated. So ctDNA guided switching to camizestrant upon detection of these ESR1 mutations, but prior to clinical progression, led to a substantial improvement in first-line PFS, and this was a very well-tolerated regimen. But the question is there really clinical utility to approaching patients this way versus just waiting for them to have progression and then changing their treatment? So we don't have any survival data yet from this study. And then again, what would really be important is looking at what happens in patients who get early switch like this versus getting sequential therapy, such as what's shown here. And we don't have that data because of the way the trial was set up. There isn't built-in crossover, so we're really not going to have that assessment. And we know that second-line CDK inhibitors plus a SERD, as was seen in Ember 3, is clearly an active regimen. So I think we definitely could use some more follow-up here. Lastly, in triple-negative disease, in the last 7 seconds, there was a important study, ASCENT-4, which is asking whether the TROP2 ADC, sacituzumab govitecan, plus pembrolizumab is superior to conventional chemotherapy plus pembro in first-line PD-L1 positive triple-negative patients. And unlike all the other studies I showed you and most other registrational studies, this trial actually provided crossover sacituzumab to the patients on the control arm, and I think they should be lauded for that. This was the primary endpoint, progression-free survival. You can see it favored sacituzumab pembro with about a 3.5-month improvement in progression-free survival, highly statistically significant. Overall survival favors SASI as well, but very immature. Response rates actually were pretty similar between the two arms, but the patients who were on the SASI pembro arm had more durable responses once they had them, and they had a little bit higher rates of complete response. Toxicity was just what you'd expect from the two classes of drug, and fortunately, the immune-related adverse events, if anything, actually seemed lower in incidence in the patients on the sacituzumab arm. So SASI pembro does lead to improved progression-free survival compared to chemo pembro. There doesn't seem to be any new safety signals to worry about over conventional treatment. We don't have survival data yet, and in this case, PFS2 should actually be informative as to whether this kind of approach should be used in the first-line setting, because there was crossover. So if approved, I do think this makes for a pretty reasonable first-line standard of care for the PD-L1 positive patients, and for the PD-L1 negative patients, we are going to have data on sacituzumab and datopotamab in the first-line setting in a similar designed trial without pembrolizumab at I think ESMO this year. So we'll be able to kind of fill in the pieces for how to use ADCs in the triple-negative population soon once we have those results. So I will stop there. Sorry to go a minute over, and I think now we were going to have a panel. Thank you.
Okay, that's wonderful. We can maybe take questions after the panel as time permits. So who's leading the panel? It's Dr. Lustberg, who's the division chief of our breast cancer division, and she'll introduce her fellow panelists.
Great. Thanks so much. Thanks, Ian, for that great review. We have a med-onc panel. The surgeons and our radiation and surgical colleagues could not be here today, but representing the surgical and radiation specialist, we have Eric Weiner, Cancer Center Director and Physician-in-Chief. And representing the medical oncology aspects of the case, we have Dr. Sharynn Hall, who practices in Torrington and Waterbury. And we also have Dr. Neal Fischbach in our Trumbull part of the network. And they're all integral parts of the Yale Breast Network. So we'll start with the case. As you all know, there's a rising incidence of breast cancer in younger women, defined as those diagnosed under the age of 45. Depending on which data sets you're looking at, there has been an annual increase of 1 to 3% per year due to multiple factors that are not completely understood, including some lifestyle factors, but this is under active investigation. But what this means is that in our clinic, we are continuing to see younger and younger patients, including this clinical case of a 28-year-old female who found a palpable mass in her breast, that she had additional imaging that revealed a 3 to 4.5 centimeter mass that was very central around the nipple area. She had evidence of lymph node involvement in the level 1 and 2 axillary nodes. She had a biopsy that revealed a grade 3, strongly ER/PR positive HER2 negative tumor, and her lymph node biopsy was positive. She had no evidence of distant disease. Her clinical stage was a clinical T2N1. Her germline genetics panel was negative, which is what we continue to see, that the majority of breast cancer cases, including those in young women, we are not finding identifiable genetic alterations in the germline. So with that, I'm going to turn it over to Dr. Neal Fischbach to kind of talk about kind of synthesizing some of the findings and potential clinical trial options for this patient.
Well, building on the observation that pathologic complete response to neoadjuvant therapy is associated with terrific outcomes, regardless of receptor subtype of breast cancer, the I-SPY clinical trials were designed, which is a platform trial which allows comparison of standard of care chemotherapy to a variety of investigational arms. And patients who are eligible via a adaptive randomization schedule are assigned various treatment arms, and with a very aggressive schedule of imaging and biomarker analysis, we've been able to tease out a lot about what's the best way to take care of people with multiple subsets of breast cancer. So with particular pertinence to this case, for women with ER-positive, HER2-negative localized breast cancer, we have some evidence that immune therapy actually is quite effective for certain subsets of patients, and we're eager to develop biomarkers which can identify those patients. So the design of the I-SPY trial compares weekly Taxol followed by dose-dense AC, a standard reference chemotherapy regimen, with multiple other arms in which investigational agents are layered into the weekly Taxol phase. And through the I-SPY 2 trials, there have been 5 different immunotherapy arms which were recently analyzed together and found that in patients who have mammaprint high-risk 2 tumors, there is a very strong signal for benefit from immune therapy. The I-SPY trials have used mammaprint, I should have mentioned, as their predictive biomarker of choice. That's a little bit of a culture change for us in North America. We're used to using the Oncotype. But in those with mammaprint high-risk 2 gene signatures, the pathologic complete response rate was 56% to the pooled 5 immunotherapy arms of the I-SPY 2 trial, as compared to only 29% in those treated with standard Taxol, Adriamycin, and Cytoxan. And that observation has led to the design of the SWOG 2206 trial, which this patient ultimately went on, which is evaluating the addition of durvalumab to standard chemotherapy. And this design in the trial, the goal is to ultimately randomize about 900 patients with MP, with mammaprint high-risk 2 signatures to standard of care TAC versus the addition of durvalumab.
Yes, thank you so much, Neal. So the patient is obviously a younger woman who desired future pregnancy. So prior to start of chemotherapy, she was referred to the reproductive endocrinology team, had oocyte harvest completed, and as you heard, she was randomized to the chemoimmunotherapy arm on this SWOG study, and she responded well, had very swift response. She did have some treatment-related complications, and eventually her immunotherapy had to be terminated halfway through, but otherwise she was able to complete her chemo course. So going on to surgical considerations with our honorary surgeon, Dr. Eric Weiner. She had a great response on exam, and her follow-up breast MRI also showed what looked like to be a complete response as best as we could tell on MRI. Talk us through in terms of how you think about surgical considerations here.
It's a pleasure being the surgeon because I have long been accused of telling surgeons and radiation oncologists how to practice. And today I can just say how I want them to practice with having no one in the audience. So first and foremost, there is absolutely no reason for her to consider a bilateral mastectomy. We know with, I think, fair certainty that removing a healthy contralateral breast in the absence of a deleterious mutation in BRCA1 or 2 or perhaps PALB2 is not associated with any improvement in overall survival. And particularly for a woman who has estrogen receptor positive breast cancer and is going to be on endocrine therapy, the risk of a contralateral breast cancer, certainly in the next decade or so, is going to be very low. For that matter, this is someone who had or is having a great response, had a moderate-sized tumor that was 3.5 centimeters, but in fact, the purpose of neoadjuvant therapy is to allow people, one of the purposes is to allow people to have less in the way of surgery, both surgery to the breast and surgery to the axilla. I don't specifically know the exact anatomy here, and I was told that perhaps there was a reason why she ultimately underwent a unilateral mastectomy related to her breast size and other issues. But as a general rule, one does not need to excise the entire tumor bed. If a patient has a great response, you would excise around the clip that was placed at the time of the initial biopsy. And very frequently, conservative surgery can be done. It's worth noting that far fewer patients undergo conservative surgery than you would expect given the PAT-CR rate that we see when we give neoadjuvant therapy. And even in some of the initial studies looking at neoadjuvant therapy now a couple of decades ago, the proportion of people who undergo conservative surgery is only increased by about 10%, probably a little bit more today. And finally, particularly in someone who you think may wind up having radiation, all the more reason to think about conservative surgery, because most people, even more so most young people who have a mastectomy, want to have a reconstruction. And I think the simplest way to think of it is that reconstruction and radiation don't mix terribly well. We do them together at times, but there are complications with implant reconstruction, and there are many reconstructive surgeons who don't like to do an autologous tissue reconstruction if they think a patient is likely to need radiation, and in that case, the patient is only eligible for an autologous reconstruction after some significant delay.
Thank you so much. And so a patient did, due to her anatomical and availability of breast tissue, underwent a left mastectomy. Given her tremendous response in her axilla, she did not have to have an axillary node dissection and essentially was able to have the sentinel node procedure. 3 nodes were negative using dual tracer mapping. The clip node was able to be successfully removed, and she had a complete pathologic response, which is something to be celebrated, particularly in a hormone receptor positive breast cancer, where these tend to be less common. So now switching gears to Eric Weiner, playing our radiation oncologist. So in this setting of a complete response, would you consider post-mastectomy radiation and regional nodal radiation?
Yeah, so the radiation oncologists hate even more when I try to tell them what to do. So this is B51. B51 was just presented not long ago and was published in the New England Journal of Medicine in June. B51 was a study that included patients with T1 through T3 breast cancer, but all patients had to have a clinically apparent lymph node that was positive at the time that they entered, when they were, actually don't remember when people were enrolled, but in any case, at the time of presentation, they had to have lymph node involvement. They then went on to receive neoadjuvant therapy, and this was in all subgroups of breast cancer. And those patients who, after surgery, had no evidence of disease in their axillary lymph nodes were randomized to receive either regional nodal irradiation or not. So if they had a mastectomy, they did not have their lymph nodes irradiated, and for those patients who had a lumpectomy, they would have had standard tangents alone without regional nodal irradiation. The median follow-up was 60 months, and as you can see, there was no difference. This study has met with some concern on the part of the radiation oncology community, and not just here, but many places around the country. I think there's concern that the follow-up remains a little short, given the fact that there is a very small survival advantage associated with regional nodal irradiation that takes 10 to 15 years to appear, although I might argue that it's typically associated with recurrences that may happen much earlier than that. So 5 years to look for a recurrence is not unreasonable. There's also concern about the ER-positive subgroup, where if you look at that, shown in the highlighted yellow line here, it did appear that there was a benefit associated with radiation in that ER-positive subgroup. Finally, I think understandably some people worry more about very young patients. Whether or not we should is another question. And so in this particular patient, I think the ER-positive disease is what ultimately led our radiation oncologist to recommend radiation. That said, I think this is a very powerful study, and particularly for patients with HER2-positive and triple-negative disease, who almost always, if they're going to experience a recurrence of their cancer, do so within the first year, within the first 5 years, and that's particularly true in triple-negative disease. That 5-year follow-up is really pretty adequate, and if a patient has not had a recurrence in 5 years, it's pretty unlikely they will after that, and it's hard to imagine there's going to be a survival advantage if there isn't a recurrence first. So I think that what this study has led us to believe is that for patients who present with N1 disease, different if someone has more advanced nodal involvement, but if someone presents with N1 disease, clears that disease with neoadjuvant therapy, then perhaps we can omit radiation. The last thing I'll say is that for the patient who clears their disease in the axilla but still has significant residual disease in the breast, I think there's also some reason to have a little more concern because of the potential for a false negative result in the axilla, particularly if a sentinel node is done.
Great, thank you. So patient ultimately decided to proceed with radiation. And then we come to the next phase of her treatment. As you recall, she has strongly hormone receptor positive tumor. And this is endocrine therapy is actually the most important phase of her treatment in terms of risk reduction. So with this, I'll turn to Dr. Sharynn Hall to talk about the addition of CDK4/6 inhibitors to our standard endocrine therapy agents.
So I think that it's important to remember that this patient is a candidate to receive adjuvant endocrine therapy. However, despite the plan for 5 to 10 years of endocrine therapy, she remains at high risk of disease recurrence. And the factors contributing to her high risk include her premenopausal status at diagnosis, her age, and the stage of her disease. And to that end, several randomized trials have been conducted to evaluate the benefits of CDK4/6 inhibitors in conjunction with endocrine therapy in early stage breast cancer to determine if they can reduce the risk of recurrence even more. To date, all three CDK4/6 inhibitors have been evaluated, and to date, palbociclib has not demonstrated benefit in this setting. The studies that we're going to quickly review are Monarch-E and Natalie, which have demonstrated benefit in this setting. So Monarch-E was a multi-center international phase 3 clinical trial investigating the adjuvant use of abemaciclib with endocrine therapy versus standard of care endocrine therapy in high-risk hormone receptor positive, HER2 negative early stage breast cancer. Enrollment included approximately 5,600 patients randomized 1-to-1 to receive standard of care endocrine therapy for at least 5 years with or without abemaciclib. Abemaciclib was dosed 150 milligrams twice a day and was continued for a total of 2 years. Endocrine therapies included tamoxifen with and without ovarian suppression and aromatase inhibitors with and without ovarian suppression. The eligibility criteria for this particular trial included patients stage 2 and stage 3. They were high risk dependent on specific clinical pathologic features. They had to have 4 or more positive axillary lymph nodes. If that was not satisfied, they could be enrolled if they had 1 to 3 positive axillary lymph nodes and a grade 3 tumor, or a tumor size 5 centimeters or larger, or a Chi-67 percentage greater than 20%. No node negative patients were enrolled. The primary endpoints were invasive disease-free survival and also distant relapse-free survival. Common toxicities that led to early discontinuance included diarrhea, infection, neutropenia, and fatigue. Pulmonary toxicity related to interstitial lung disease was a rare toxicity. The results demonstrated that abemaciclib and endocrine therapy showed benefit in invasive disease-free survival and also distant recurrence-free survival. And this survival benefit has only improved as demonstrated in the Kaplan-Meier curve over the past 5 years. So at present, abemaciclib with endocrine therapy has a 7.6% benefit versus and a 6.7% benefit for distant relapse free survival. 5-year overall survival for this trial is pending. The Natalie trial was also an international open-label randomized phase 3 trial investigating the use of adjuvant ribociclib with aromatase inhibitor versus aromatase inhibitor alone. The patients were randomized 1-to-1 ratio to receive ribociclib at a dose of 400 milligrams daily, given 3 weeks on, 1 week off, and treatment was continued for a total of 3 years. Treatment was treatment with ribociclib was with the addition of aromatase inhibitors, either letrozole or anastrozole. Premenopausal patients enrolled in this trial also received ovarian suppression with goserelin and aromatase inhibitor. The eligibility criteria for this trial was broader than in Monarch-E. Stage 2B and stage 3 patients were enrolled regardless of nodal status. Stage 2A patients were accepted if they had 1 or more lymph nodes, grade 3 disease, a grade tumor with a high Ki-67 percentage or a high genomic score measured by the available high-risk genomic tests that we have available, Oncotype, Mammogram, EndoPredict. Invasive disease-free survival was the primary endpoint, as well as a few secondary endpoints. Toxicities related to ribociclib included neutropenia, arthralgias, hepatotoxicity, and QTc prolongation, and these were the toxicities leading to early discontinuance in some patients. So the results from the NATALEE trial continue to mature, and they demonstrate improved invasive disease-free survival of 90.7% with ribo and AI versus 87.6% with AI therapy alone. So this patient is eligible to receive both CDK4 inhibitors with aromatase inhibitor and ovarian suppression.
Great. Thank you so much. So for the interest of time, we'll just wrap things up that she did want to get pregnant in the very near future. So for that reason, abemaciclib was selected due to the 2-year duration for this particular patient. She would plan a pregnancy after completion of abemaciclib. And data supporting that course is based on the international positive study where patients who've had at least 18 months of endocrine therapy exposure could take a break from endocrine therapy, have a 3-month washout, attempt a pregnancy, and then return to endocrine therapy. So kind of the case summarizes both the latest therapeutic approaches to hormone receptor positive breast cancer as well as active acknowledgement of quality of life and survivorship issues. So with that, we'll end our panel. Thank you so much.